Liebe Kolleginnen und Kollegen, liebe Freunde des Amboss-Studientelegramms, Marcus at home welcomes Professor Stéphane Gaudry in Paris, with whom we would like to discuss indications for initiating or for not initiating renal replacement treatment in patients with acute kidney injury. Stéphane, thanks a lot for being our guest. Thanks for taking the time.
Thank you.
Professor Gaudry is intensivist. He is professor at the Département de Réanimation Médico-Chirurgicale at Hôpital Avicenne in Bobigny, Île-de-France, and at the Sorbonne Université in Paris, France. He has initiated and conducted landmark trials in the field of renal replacement treatment in acute kidney injury, comprising the AKIKI 1 and AKIKI 2 studies, which have been published in New England Journal and Lancet, respectively. And he has written a meta-analysis and a review paper on initiation of renal replacement treatment that again were published in Lancet and in the New England Journal of Medicine, respectively. My co-moderators today are Sarah Morell from Frankfurt, Germany. Both Sarah Morell and me are very honored and pleased to have Professor Tilman Drueke as co-moderator, who is a legend of clinical and experimental nephrology, both in France, in Germany, and surely even beyond national borders in Europe and globally. Among many academic duties, Professor Drueke is emeritus editor of NDT, and I just learned that he did his medical studies partly in Frankfurt, Germany. So this talk links Germany and France, it particularly links Frankfurt and Paris. It's a pleasure to have all of you today. I would like to suggest to start with an imaginary patient who comes to our ICU. So it's a male patient, say 66 years of age, who has been otherwise healthy, and he undergoes major non-cardiac surgery. Before surgery, he has a normal creatinine, and then day 2 after surgery, he develops sepsis. He goes to intensive care unit, and he has on day 2, say, a creatinine of 2.0, a urea of 100, and then we wait for 1 or 2 further days, and on day 4, creatinine goes up to 3.0, and urea goes up to 150 milligrams per deciliter. So when should we consider starting renal replacement treatment in this patient, Stéphane?
So it's an interesting clinical case. At first, the first question is there any life-threatening condition that mandates renal replacement therapy urgently? So we know, and everybody know now, that there is 3 urgent indication to start renal replacement therapy. In KDIGO guidelines 10 years ago, it was stated like that. The severe and refractory hyperkalemia, the severe and refractory metabolic acidosis, and the severe and refractory pulmonary edema resistant to diuretics. So one question could be, what is severe and what is refractory? And severe, it's quite difficult. It depends. For hyperkalemia, the severe hyperkalemia is when there are some consequences on the cardiac function. But refractory, it could be after 1 medical treatment or 2 medical treatment, 1 or 2 steps. We don't know exactly, but we can say that in the first step, we can use medical treatment for hyperkalemia. It is the same for metabolic acidosis. We can use medical treatment, and we have one important study, randomized control trial on this question, the BICAR ICU study, which was a French trial assessing the use of bicarbonate and intravenous for patients with metabolic acidosis. And in this study, the study was negative, but patients who had acute kidney injury had better outcome with this medical treatment compared to the placebo, and they use less frequently renal replacement therapy in the interventional group. And the third group of patients with pulmonary edema resistant to diuretics, of course, there is no question in this context, we have to start renal replacement therapy for ultrafiltration. So after this, in the absence of life-threatening condition, there are two strategies. The early strategy, in the early strategy, we start renal replacement therapy because patients present severe acute kidney injury, and in this context, patients had severe acute kidney injury. And a delayed strategy. The delayed strategy could be 2 or 3 days delayed after the start of severe acute kidney injury. But of course, if you use this delayed strategy, you are waiting also the life-threatening condition that will mandate renal replacement therapy urgently. And the question is, what is exactly the delay strategy? But we know that now we have many randomized controlled trials comparing early and delayed strategy, AKIKI, ideal ICU, START AKI, major randomized controlled trial, which show that there is no difference according to mortality when you compare an early renal replacement therapy strategy and a delayed one. And the advantage of the delay is that you use less renal replacement therapy, from 44% to 50%, according to the definition of the delay strategy in the different trial. In AKIKI, 50% of patients never receive renal replacement therapy in the delayed group. So it's a major difference. There are also probably secondary advantages, for example, less infection and complication from renal replacement therapy catheter. So in this condition, we can probably wait, but we will discuss this after probably, but the question is, what is exactly the limit in the delay? And that's the question we assess in the AKIKI 2 trial.
And I can just come back with these urgent indications. Do you have a strict level of potassium and a strict level of pH where you start? Because I guess nobody of us would start treatment in patients with a potassium of, say, 5.9 or something like that. Or do you decide for each individual patient individually?
Yeah, we have to assess individually, exactly, because some patients, for example, they can tolerate 6.5 or even 7 millimole per liter. For example, you know, if we assess if we assess blood potassium after exercise, intensive exercise, your blood potassium will increase until 8 millimole per liters, but with no consequences. Of course, you are in good health. But so in ICU, we have to assess the consequences on the cardiac function. And if we, in clinical practice, we use EKG or echo to assess the cardiac function. And if there is a consequences of hyperkalemia, even if it's only 6, we can start a renal replacement therapy. But sometimes they are the combination of hyperkalemia and metabolic acidosis, and we have to discuss this both indication. For metabolic acidosis, the limit in the studies is between 7.15 and 7.20. It depends on START, IDEAL, or AKIKI trial, but you know, it's less than 7.2. But we can use BCAR infusion before to start renal replacement therapy, and we can also set the mechanical ventilation in the context of patients under invasive mechanical ventilation.
I particularly like one clear statement in your wonderful New England review article, where you state that the role of kidney replacement therapy in most forms of lactic acidosis, with the exception of metformin toxicity, is controversial, as extracorporeal lactate clearance is substantially lower than endogenous turnover, which limits the efficacy of this approach in altering clinical outcomes.
Yeah, of course, and lactate acidosis, lactate is only a biomarker of the consequences of the shock. But sometimes we also think that it could be interesting to start renal replacement therapy in context of lactate acidosis with sepsis shock. But we have now many data showing that there is no advantage for hemofiltration or even hemodiafiltration or intermittent, I don't know, to use this kind of technique to improve the prognosis of patients with severe sepsis or septic shock. One of the first trials on this question was published more than 20 years ago. Not published, but performed more than 20 years ago, but published probably 18 years ago in critical care medicine. And it was the use of hemofiltration at the very beginning of the septic shock. And this intervention was associated with more organ dysfunction during the follow-up. So we know that it's impossible to treat sepsis with hemofiltration or hemodialysis.
You have clearly pointed out that all major trials that compared early or delayed initiation of renal replacement treatment in acute kidney injury found no benefit, be it AKIKI, Ideal ICU, or START AKI. There's one single exception, which comes from my hometown, Münster, which is the Elaine study, in which a very early initiation of renal replacement therapy seems to be of benefit. So how comes that this study has so different results compared to all the other trials?
So it's quite a very interesting question. So it has been discussed by some experts in the field, and an expert who was the senior editor on nephrology, dialysis, and transplantation. I remember his word in the American journal. He said that Elaine trial assess the efficacy of renal replacement therapy in patients who really need it. And that's it. This is great. That is exactly the problem. In the Elaine trial, the study was a single center randomized control trial. Okay, it was positive in single center randomized control trial. All the other trials are multi-center, some internationals are like START AKI with many more patients, but that's not the question. The question is the design of Elaine. And Elaine trial include patients after surgery, mostly cardiac surgery, and more than 70% of patients had pulmonary edema or large fluid overload at the beginning, at the randomization. And in my opinion, and it's not my opinion, only my opinion, but the opinion of many experts, that explain why Elaine showed that we should start. Of course, we should start when there is a pulmonary edema, and especially after cardiac surgery. It's very important in our patients who are very susceptible from pulmonary edema after cardiac surgery. So this is my response, but I know that Alexander Zarbok probably another interpretation of this trial, but okay, the trial is included in a large meta-analysis we published in the Lancet. It was an individual patient data meta-analysis, so we include whole patients and we review all the data, and including this study with the other one, excluding START AKI, because START AKI was not published at the time we published the meta-analysis. The meta-analysis showed that there is no difference between early and delay, with an hazard ratio of 1.01 and very small confidence interval. So I think this is not the question now. We know that it's not the standard of care is now to delay renal replacement therapy in the absence of life-threatening condition. And this recommendation has been endorsed by recent guidelines on sepsis published a few months ago.
And if we follow Elaine, we would have to dialyze many patients, because that really started very early, I think in stage 2 of acute kidney injury, unlike all other major studies, which started just in AKI's stage 3. So I would have one last question. I understand that there may be no advantage of immediate dialysis if you don't have an urgent indication, but why may waiting for some days be even beneficial? So not just neutral, but may even have some beneficial outcomes. That sounds at first look somewhat contradictory.
Well, there is a very important advantages for waiting. We show in the AKIKI 1 that patients who were included in the delayed group had better renal function recovery. When we hypothesize that renal function recovery is the recovery of adequate urine output or decrease of creatinine, plasma creatinine without renal replacement therapy. But it was only an hypothesis, you know, because it was secondary outcome. It was the first large randomized controlled trial on the field in AKIKI 1, and we propose the hypothesis that renal replacement therapy in the early strategy may delay the renal function recovery. And we propose the concept of artificial kidney-induced kidney injury. Maybe you know in mechanical ventilation, ventilator-induced lung injury. So it's probably the same with artificial kidney for renal replacement therapy. And this concept was discussed in different paper with different experts in the world and with our team. Before start AKI, it was difficult to confirm our proposition. But now Start AKI is published, and we know in Start AKI that patients who were included in the delayed group, in the early group, were more frequently dependent from renal replacement therapy after 3 months, after 90 days. 10% versus 6% in the delayed group. And the renal replacement therapy dependency after 3 months, it's not the consequences only of the first episode after randomization. So it's probably the consequences of the intervention, and 90-day, it's very important because it is a limit between acute renal disease and chronic kidney disease. So Start AKI confirm that an early strategy, an intensive strategy for renal replacement therapy in ICU is associated with more risk for chronic kidney disease.
So as we've learned so far, as you've just told us, delaying renal replacement therapy in AKI is not harmful, and in fact may prevent complications related to dialysis and reduce renal replacement therapy dependence in the long run, as you've just said. So after AKIKI, you decided to start a new study in 2021, so the AKIKI 2 study. And my first question would be, why did you decide to do the AKIKI 2 study?
So AKIKI 2 is, it's a very important study in my opinion, because the question of the delayed strategy was not totally clear. The response of the from the question of AKIKI 1 and ideal ICU and Start AKI, because it was not clear the time we can wait in the delayed strategy. So is it 2 days, 3 days, 5 days, or 10 days without renal function recovery, but of course with the absence of life-threatening condition. So in AKIKI, we had 5 criteria for renal replacement therapy in the delayed group. The first 3 criteria, of course, it was the life-threatening condition: severe hyperkalemia, severe metabolic acidosis, pulmonary edema. And we also used 2 safety criteria to start in AKIKI 1. Your anuria for more than 3 days, oligoanuria for more than 3 days, and blood urea concentration greater than 40 millimole per liters. Sorry, I use millimole per liters. In French, we only use that. So sometimes it's difficult, but sorry. So the threshold of urea concentration was 40 millimole per liter. And we think that the last 2 criteria, the duration of oligonuria and the threshold of urea concentration, was not life-threatening condition, not urgent indication. And we try to prolong this delay strategy, and we propose a more delay strategy with a threshold of urea concentration of 50 millimole per liters and no delay for oligoanuria. And it was the AKIKI 2 trial. And with these two strategies, the standard delay strategy and the more delay strategy, we assess a composite outcome of exposition of renal replacement therapy and mortality, which is renal replacement therapy 3 days. I say a composite outcome because if the patients die before 28 days, we consider that he received renal replacement therapy during 28 days. So the mortality is important, the death is important in the assessment of this primary outcome. And the primary outcome, renal replacement therapy 3 days in the AKIKI 2 trial, did not significantly differ between the two groups. And in the more delay strategy, only 20% of patients never receive renal replacement therapy. So it's not a lot of patients. At the end, many patients receive renal replacement therapy. But, and it's probably very important, we assess different secondary outcomes. And on the first analysis, the deaths after 60 days did not significantly differ between the two groups, but the p-value was 0.07. So we can discuss about the magic p0.005, but when it's 0.07, it's interesting to what's happened exactly. And the fact is that we decide to perform a pre-specified analysis before the study, including many data, and to assess the mortality after 60 days. And in this pre-specified multivariate analysis, the odds ratio for mortality after 60 days was 2.16 for the more delayed strategy. So we can say that this more delayed strategy is associated with a risk for increased mortality. We can say that. And it is very important because the AKIKI 2 trial gives us the answer of what is exactly delayed. Probably now we know that after 3 days, we should start. Even in the absence of life-threatening condition, we should start. So 2 or 3 days, it depends on your mind. And in my opinion, it depends on your organization. For example, if it's 3 days, but it's 4 o'clock in the morning, you can wait your staff, your team in the morning, and you will start renal replacement therapy in the morning for your patient. It's not urgent indication. On the other side, if it's afternoon, Friday afternoon, and you know that tomorrow probably there will be not many doctors in your ICU, and tomorrow it will be 3 days without renal function recovery, you can start on Friday. So you can organize the practice of renal replacement therapy in your ICU with this result of AKIKI 2.
That's great. That's already answered so many of my questions. So as you said, one of the criteria to initiate renal replacement therapy was the blood urea nitrogen concentration. I had some questions about that, if that's okay. So why didn't you use other markers such as creatinine or modern biomarkers of AKI?
Oh, thank you for your question. We heard a lot about urea encephalopathy. So the consequence of uremic toxin on the brain function. And in ICU, we have many patients with confusion, delirium in ICU, and problem with mechanical ventilation, and it's difficult to manage this kind of patient. And sometimes we say, okay, the problem is that because the urea concentration is high, so there are many uremic toxin nobody know exactly what is it uremic toxin, but they say the problem is urea. So sometimes they think that it will be better to hemofiltrate or hemodialyze the patients with high level of uremic toxin. But in my opinion, it's only a biomarker. We have many other things that could explain brain dysfunction in ICU. For example, medication, antibiotics, or sedation, a lot of medication we use. And possibly when we start renal replacement therapy, we have less antibiotics or other molecule, I don't know, we use in the ICU. It's possible. It's possible to see also that uremic toxin play a role in brain dysfunction in ICU. But we will probably in next weeks publish a study on the brain dysfunction in AKIKI 2. And you will see that this is very interesting, but I cannot tell you the results. Next time.
Okay, looking forward to hearing that. So do you believe then that blood urea nitrogen is a good marker to use in everyday clinical life in severe AKI? And if so, which cutoff should we use?
I think it's not. Creatinine is not a good biomarker. Urea concentration, yeah, probably after 40 millimole per liter, you have to say, AKIKI to say, okay, it's time to start. But, I think there is not a magic threshold, of course. For example, if you receive a patient and it's very beginning of the stay in ICU of your patient, in the first hours, probably he was in his home and he stayed in his home during 3 days with fever, septic shock, I don't know, and he arrived in your ICU with 40 millimole per liters of urea concentration. I think you can wait. You can wait, and if it's possible to manage your patients conservatively, you can wait few hours and possibly the patient will recover. So there is no magic threshold for urea concentration.
Okay. And another question about the survival. So as you've said, survival didn't or wasn't significantly different in the two groups, even if the significance was 0.07. What drove this difference though? Why do you think there was a difference between the delayed and the more delayed group?
Yeah, I don't know exactly, but when we analyze patients who were randomized on the urea criteria or on oligonuria criteria, there is no difference between the two populations. But I think we have only more than 250 patients, but it's not enough to show something like that. And it's very difficult to see what exactly is play a role in the mortality, in the increased mortality. Possibly it's many things. That's why we ask the question from brain dysfunction, because if there is brain dysfunction, the brain dysfunction probably will delay the mechanical ventilation stop, and probably patients will stay under mechanical ventilation more longer. So I don't know exactly why, but there are many hypotheses.
And my last question would be, before moving on to more general topics, did any of the results of the AKIKI 2 study surprise you? Were you expecting to get any other results?
No, I at the beginning I thought that there will be no difference between the delayed and the more delayed strategy. So I was very interesting when I saw that probably the more delay was associated with increased mortality, because it's a positive trial, and that give many answers to many questions we asked during ICU stay. Because after the AKIKI one, many intensivists told me that they wait many times 3 days, 4 days, in the absence of severe hyperkalemia or severe acidosis, they wait. And I thought that, okay, they wait, but they did not use the delay strategy we use in AKIKI 1. They use their delay strategy, and in their delay strategy, it was a very more delay strategy. So now they can change their practice and correct the time when they start renal replacement therapy. So yeah, I was not surprised, but it was not my, I thought that it will be negative.
Yes, thank you very much. Very interesting discussion. I am not an expert in AKI, but still I have been trained as general nephrologist and so have general knowledge in AKI, of course. My first question is, when I read your recently published secondary analysis of 2 multi-center randomized controlled trials, that finally you concluded, and that's an issue which has not yet been discussed up to now, you concluded that you would rather use intermittent than continuous renal replacement therapy. This was based on 2 multi-center studies. But what I saw is that in these studies, the precise technique of either hemodialysis or continuous renal replacement therapy was left to each center to decide. So let's say which bicarbonate concentration, is it dialysis cooling or not, what time exactly? And would this not be a kind of, I would say, a problem in interpreting these this conclusion?
Yeah, you're right, and that's exactly why we state in the conclusion of the manuscript that it's only hypothesis generated. There is a major difference between the use of intermittent renal replacement therapy in France and, for example, compared to United States or North America. In France, we use many times intermittent hemodialysis in patients in ICU. For example, it's probably 50% continue, 50% intermittent. In North America, it's more than 80% continue renal replacement therapy. And the first question that is there, we will discuss our study after, but is there a reason to start to use continuous renal replacement therapy more than 80% of your patients in North America? In my opinion, in the evidence-based medicine, evidence-based research, there are no argument to start only continue, because there is only one large randomized controlled trial comparing intermittent and continue in multi-organ failure patient, in septic shock patient. It was the HEMODIAF trial published in The Lancet in 2006. And in this study, there is absolutely no difference in terms of mortality after 60 days. And even if you look at the Cochrane review, there is a meta-analysis on this question, and the mortality is the same between intermittent and continuous. There is only one positive trial which came from Rabindranath in San Diego, published in 2001, and in favor of intermittent hemodialysis in ICU. It's strange because they use only continue in San Diego. So it was a time to reassess this question, because these trials on modality continue versus intermittent were very old trial, more than 15 years ago. And now we have many change in intensive care, the prognosis of our patients improved in the last years, and we have many progress in modalities. So it was an interesting question. And that's why we asked this question in this secondary analysis. And you're right, they are probably, the group are not comparable, but we use a propensity score analysis. Mm-hmm. And this propensity score analysis was quite well when you look in the supplementary material. And so it's the result. And the result is that intermittent is associated with better outcome, and that probably it's explained in patients with less severely ill patient at ICU admission. But we should say that in France, intensivists, nurses are very specialized in intermittent hemodialysis. They use many times this technique, and it's probably explained this result. I don't know, but the conclusion is that we need new randomized control trial to assess this question, because it's very interesting, and probably there are consequences not only on mortality, but possibly on renal function recovery after 3 months or, I don't know, 1 year. And we asked for a grant to assess this question in a new randomized control trial, because now we know the renal replacement therapy indication, and we have to progress on renal replacement therapy modalities.
And in this new study, there will be more precisely defined techniques in each group. Yeah.
Yeah, of course, and we will use. You know, there is a very nice paper from Frédéric Shortgun, a French intensivist. She published this paper 20 years ago in the American Journal, and it's a major paper on a before-after study with very simple things, simple setting for intermittent, and that improve hemodynamic tolerance of intermittent hemodialysis.
My second question, very brief question. When do you use heparin? When do you use citrate? And when do you use neither of them?
So we know now that probably citrate is good for continued techniques, of course.
Yeah.
Not for intermittent, but for continuous technique, citrate is a good option. However, here again, the largest trial is recently published, I think in the JAMA, by Alexander Zarbok, and the result of the study show that the lifespan of the filter is expanded in the citrate intervention group. Okay, it's better, and there are probably less hemorrhage in the group of patients receiving citrate. But there are also secondary outcome on, I remember, I think it's liver failure or something like that, and so there is no difference in terms of mortality. I know that probably the outcome mortality is not the good one in the study assessing citrate compared with heparin, but in the paper published in the JAMA, they use a co-primary outcome with the mortality. So this is a negative trial. So in my opinion, you can use citrate, but only in the context of experienced team. Your team should be aware of the complexity and the risk to use citrate.
How about patients at very high bleeding risk? Do you use intermittent hemodialysis techniques without any anticoagulation?
Yeah. It's possible to use intermittent technique with an option without anticoagulation, and it's very simple. And also, in my opinion, it's the best technique in this context, because in the context of hemorrhage, many times you have to go to the surgery room, surgical room, or to go to the radiologic intervention. And so you have to move your patients. So if you use continue, it's impossible to move your patients. So use intermittent with no anticoagulation. It's better in this context of hemorrhage and a risk like that.
But these dialysis sessions should be very brief, short, 3 hours, 4 hours probably, because otherwise you will have clotting.
Yeah, but it's enough sometimes, 2 hours, 3 hours. For example, in my clinical practice, at the beginning of renal replacement therapy, I use a 2 hour session or 3 hour session, because Sometimes we start with risk for osmotic disequilibrium. So it's better to use 2 or 3 hours at the beginning and after more.
My last question, did the newly or recently introduced potassium binders or exchangers change the indication in terms of threatening hyperkalemia, allowing to postpone dialysis more to a more delayed time?
I did not see a new study on this, and I did not plan to perform a trial like this or a study. But we discuss sometimes with my friend from the nephrologic care, and they are interesting to perform this kind of study. I think we will do that in the future.
So there's not yet any answer to this based on RCT?
No.
Thank you for answering my question so brilliantly.
Thank you very much.
Before Sarah Morell takes you back to Paris, I would have 2 final questions. The first one would be on biomarkers, because in clinical nephrology, there are ever new biomarkers suggested to be introduced into clinical nephrology. I know your standpoint on this. I like your standpoint on this, and I would be very happy if you share your ideas with us.
So I will be clear. Biomarkers are very good to discuss in Congress. Biomarkers are very good to publish many studies in many journals, and biomarkers are also very good for the industry. But in clinical practice, I never use biomarker except creatinine or urea plasma concentration. But new biomarker, there is no troponin for kidney function. I'm sorry. I'm really sorry. And even if we had that, many times I use this example with my friends from intensive care. For example, if you had a very good biomarker for COVID-19 patients, acute respiratory distress syndrome, and the biomarker in the emergency department say that your patient will need invasive mechanical ventilation in 3 days, but your patient is under 3 liters per minute of oxygen. Are you going to start mechanical ventilation in the emergency room? Of course not. You will wait and you will start when it will be necessary. So it's exactly the same in the biomarker field and renal replacement therapy timing. It's the same. But in my research, I use biomarker because it's interesting to assess, pathophysiological question on the acute kidney injury. It's very interesting. But in clinical practice, I don't know. Sometimes it took hours in the Congress to talk about biomarkers, and 2 years after, the biomarker, we talk about another biomarker, and it's always like that since 15 years.
So we learned that we will be soon able to read your data on brain function in patients who participated in the AKIKI trials. We learned that you are currently designing a novel study that will compare different treatment strategies based upon your findings when to initiate dialysis treatment. But there's a third field of interest that you're currently working upon, and this is the field of vitamin B3 in acute kidney injury. Would you give us some ideas why vitamin B3 might be of interest?
Yeah. So it's an interesting study published 4 or 5 years ago in Nature and Nature Medicine on vitamin B3 and renal function recovery or renal dysfunction after cardiac surgery. and probably vitamin B3 and this vitamin and other pathophysiological vitamin are implicated in renal function recovery. So it could be interesting to assess the efficacy of this vitamin at the very beginning of the acute kidney injury, because we know that renal function recovery, the recovery of the tubule, of the cell tubules, start 24 or 48 hours after the acute kidney injury. So we will assess this question in a pilot study for critical care patients, but I know that there is another trial in progress on this question, probably not only in France, but also in the United States. So we will see. And if, for example, if we show that vitamin B3 is associated with more rapid renal function recovery, that explains why. That's an explanation for the impact of renal replacement therapy on the delay of renal function recovery. Because if you start renal replacement therapy, the vitamin B3 will be epurate. So it could be a mechanism to explain the delay in renal function recovery after renal replacement therapy.
So I'm going to end the interview with a little question in French. Donc on fait notre petit tour de France et on veut s'arrêter à Paris. Quels sont vos lieux incontournables quand on est à Paris? Où est-ce que vous aurez
quand on y va pour la première fois ou quand on connaît bien?
Quand on connaît, donc les petits secrets.
Ah, les petits secrets de Paris.
Ah ouais.
Alors là...
les petits secrets de Paris. Bon, les quartiers très, très sympas, les quartiers du côté de Bastille. Il y a un quartier qui est moins fréquenté par les touristes que par les endroits, des petites rues où vous pouvez aller vous promener et un peu vous perdre et découvrir des jolis restaurants, des jolis bars, des petits endroits sympathiques. Donc ça, j'aime bien aller par là parce que c'est un endroit qui est plutôt sympa. Et puis, en fait, moi, j'aime bien aller au théâtre. Et donc, autour de la gare Montparnasse, qui est située dans le sud de Paris, il y a beaucoup, beaucoup de théâtres. Plein de petits théâtres, même il n'y a que 30 places ou 40 places, avec des petites pièces qui changent tous les jours. Et ça, c'est très sympa pour y aller. Et puis sinon, dans Paris, il faut toujours rester dans Paris apparemment.
Oui.
Ce qui est quand même très sympa à faire, moi j'aime bien faire ça, c'est se promener le long des quais qui maintenant sont des voies qui sont sans voiture, et se promener le long des quais en vélo ou à pied dans Paris quand il fait beau, c'est vraiment très 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 sympa parce qu'en quelques heures, on a vu tous les grands monuments qui tournaient autour de cette zone-là qui est dans Paris Centre et qui est très sympa.
Super, merci beaucoup.
Je suppose que vous connaissez les grands musées, le musée d'Orsay.
Oui, le musée d'Orsay.
Est-ce que vous avez regardé la Sainte-Chapelle déjà, visité la Sainte-Chapelle?
Oui.
C'est magnifique.
Ah,
Notre-Dame, il faudra attendre un peu, mais la Sainte-Chapelle, elle est toujours accessible. Hein.
Mais Notre-Dame, je l'ai visitée avant qu'elle brûle. Hein.
Oui, nous tous, oui.
Non, bien sûr. Le musée d'Orsay, c'est magnifique. Et puis surtout, l'architecture du musée est fabuleuse. C'est une ancienne gare parisienne, et donc c'est absolument super.
Et le musée Picasso a été complètement rénové. Mais moi, je ne le trouve pas mieux qu'avant. Je l'ai visité avant et maintenant. Donc, mais enfin, c'est toujours intéressant à voir. Hein.
Ouais, il y a Rodin aussi.
Ah oui,
être un peu dehors.
Très, très.
Bon.
Vous connaissez le musée Rodin?
Oui.
Non, mais je parle...
Moi, je ne connaissais pas, pour être honnête. Non, à voir la prochaine fois, donc quand je serai à Paris.
Ouais.
C'est bien.
Donc, il y a plein de choses à voir.
Merci beaucoup.
Eh bien, c'était la dernière étape de notre tour de France académique. Merci à toutes et tous ceux qui ont participé. Merci à la Société francophone de néphrologie, dialyse et transplantation, et en particulier à Sarah Morell pour avoir planifié notre voyage de Copenhague à Paris. L'année prochaine, le tour va commencer à Bilbao et j'espère retrouver les collègues français et espagnols l'année prochaine. Et le dernier mot sera à Sarah Morell.
Merci beaucoup pour cette interview.
Merci.
Thanks so much for being here, for answering all the questions. It was a delight to have you.
Thank you very much, and see you probably in Paris.